The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to today's webinar, Medicare, How Safe Is It? Before we get started, I would like to go over a few items so that you know how to participate in today's event. When you join today's webinar, you selected to join either by phone call or computer audio. If for any reason you would prefer to change your selection, you can do so by accessing your audio pane in your control panel. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send your questions in at any time. We will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce John Feather, CEO of Grantmakers and Aging and moderator for today's event. John?
Thank you, Kat. I'm delighted that so many of you have joined us today. Before we begin, we want to thank West Health, whose support allows us to offer this webinar free of charge to our members. Politicians on both sides of the aisle praise Medicare as the guarantor of health insurance for older and Americans with disabilities. But underneath their appreciation lies a serious disagreement on future Medicare financing. Multiple Republican budgets have proposed to transform Medicare from a defined benefit paid for by the government to a defined contribution paid as vouchers that people use to buy private insurance. Advocates for premium support claim this change is necessary to promote efficiency and save Medicare for growing numbers of future older Americans. Opponents counter that premium support will shift risks and costs to individuals, reducing federal costs at the expense of affordable protection for all beneficiaries. Here with us today to explore these issues is Dr. Judith Fader, Georgetown University professor and Medicare expert. A nationally recognized leader in health policy, Judy has made her mark on the nation's health insurance system through both scholarship and public service. A widely published scholar, Judy's health policy research began at the Brookings Institution, continued at the Urban Institute, and since 1984 flourished at Georgetown University. From 1999 to 2008, Judy served as dean of what is now the McCourt School of Public Policy at Georgetown University. And as dean, she built Georgetown's Public Policy Institute into one of the nation's leading public policy schools, whose graduates participate in policymaking, policy research, and policy politics, not only throughout Washington, but throughout the world and the nation. As it was mentioned, if you have questions, you can type them in at any point, particularly if you have clarification questions. We can ask Judy to clarify those, and I'll be asking her the questions that you list at the end. So at this point, I am very, very happy to bring on Dr. Judy Fader. Judy? Judy, do we have you online?
You should. Do you have me now?
I do have you now. Great to hear. So I'll let you take it away.
Okay, I will then. I just said hello to nobody, so now I will say hello to everybody. And thank you, John. The focus on the repeal and replace of the Affordable Care Act has pretty much dominated healthcare politics in 2017 and may not be over with. That conflict has been so intense that Republicans may be reluctant to take on another critical issue, specifically Medicare. But based on experience, I would never underestimate Speaker Paul Ryan's commitment to what he calls entitlement reform, a policy that would transform Medicare along with Medicaid financing to undermine the guarantees both provide to individuals of access to care. Now, the budget resolution does, in fact, include Ryan's proposals for Medicare, but largely, as I understand, at least at this point, in rhetoric and not actual instructions for policy change. But I would say we should think of his policies and his perseverance in pursuing them as setting the stage for our conversation today. So next slide, please. Let's look at Medicare reform and what it is actually about. More specifically, we want to talk about what's driving the demand for this reform and consider whether there really is a case to be made for reforms. Then we want to look at what reformers are seeking, and that goes under the label that some of you may be familiar with of premium support, which I will explain. The question is premium support a threat or a promise? Next slide, please. And it will become obvious fairly quickly. I'm going to focus on highlight the degree to which it's a threat, and therefore I want us to think about what else reform could look like. Specifically, what actions we need to make Medicare protection as meaningful as it ought to be. And then finally, whether saving Medicare is a matter of what we can afford or about what we will value. So let's go first to the case. The critics argue that Medicare spending is what they call unsustainable. And as you can see from this slide from CBO, Congressional Budget Office material, Medicare spending is growing, not simply in absolute dollars, but as a share of the federal budget and as a share of the nation's economy. So if you look at the level of Medicare outlays as a share of the budget in 2017, which is the second bar from the left, it's at about 14.9%. And then go to the right, in the next 10 years, it's expected to rise to 17.8% of the budget. And if you look down at the bottom of the slide, you can see that in that same period, it's growing from, or projected to grow, from 3.1% to 4.2% of GDP. Now, that's real. That is real and meaningful expenditure growth. But it doesn't mean that the growth is unsustainable. The second charge on the next slide that critics make is that Medicare is going broke. And here we can talk about the facts. Part of Medicare, the hospital part, referred to as Part A, is funded through payroll taxes. The rest of Medicare is general revenues and premiums. And when payroll taxes that come in are greater than spending, they are earmarked for Medicare funding and go to a trust fund. And then Medicare bills are paid from those revenues and interest on, or ultimately the funds in, that trust fund. Now, what you can see on this slide from the Medicare Board of Trustees is that in 2029, go straight to the bottom, that trust fund will be exhausted. There won't be any more money in it. Now, just as a heads up to what's coming, look up the chart to 2009, and you'll see that the trust fund was projected to be gone this year. So as we're going to see, you can move that line, and now the exhaustion of the trust fund is projected for 2029. Now, a couple of things to say about what that means, the exhaustion of the trust fund. It does not mean that Medicare is bankrupt. It doesn't mean that all the money's gone, because the tax revenues keep coming in. And it's estimated that those tax revenues, the payroll taxes that the working population pays every year, will, after the trust fund is exhausted, cover almost 90% of Medicare costs. So there's a hole there, but it is not bankruptcy, and it's only affecting this part of Medicare. It also, as I indicated by having you look at how that line has moved after the ACA, it doesn't mean that there's nothing we can do about the adequacy or the availability of the trust fund. So if we go to the next slide, we can see how much that line, or we see further evidence of how that line has moved. If you look at the top line, and this again is Congressional Budget Office data, if you look at the top line, these were CBO projections of how Medicare would grow that were made in 2009. The bottom line are the projections that were made in 2016. CBO had to modify its projections several times over this period because actions taken in the Affordable Care Act and some other things going on in the healthcare system so dramatically slowed the growth in healthcare spending and in Medicare spending. The key that we've learned from that is controlling provider payments, not just in Medicare, but in the whole healthcare system. In fact, Medicare, as we'll see from the next slide, is better at constraining the rate of growth in its spending than is private health insurance. On the left on this slide, the bar shows the annual growth rate of total Medicare spending. This is from Board of Trustees, Medicare Board of Trustees data put together by the Kaiser Family Foundation. So the total rate of growth is 7.2%. That total is a function of the growth in costs per person, costs per enrollee, and the number of enrollees. When we look and think about what's happening with healthcare spending, we want to focus on that per enrollee or per capita spending. And as you move to the right on the slide, you see that Medicare per capita spending is growing at 4.5%, almost a half a percentage point more slowly than private health insurance per capita spending, which you see on the right. Now, the other thing that you can see from this slide is that only a little over half of Medicare spending growth is associated with the growth in the cost per capita. The rest is about the growth in the number of capitas, the number of older people qualifying for Medicare. And that growth, which we all know is from the aging of the baby boom, it's hard, particularly since I am a baby boomer, to consider that a flaw in the program. It is a reality that we have more people becoming older, increasing the costs of the program. So to sum up what we've looked at so far, what's real is that Medicare care costs are growing relative to the economy and the rest of the federal budget, and faster than the revenues dedicated to the hospital care that Medicare pays for it. So the question is that a reason to transform the program and to transform the Medicare financing? Republicans, then I'm going to use Speaker Ryan's many proposals to speak from at this point, they argue that it is. So now let's look at their specific proposals. I mentioned that they're referred to as premium support on the next slide. Premium support would transform Medicare financing from what it is today, a defined benefit paid by the federal government as the insurer. So people know what benefits they are entitled to receive, and it is the government as their insurer, the Medicare program pays for them. That's the way it operates today. Premium support would transform that defined benefit to a defined contribution, a dollar amount that beneficiaries would receive to use toward the purchase of insurance. Interestingly, it's pretty much like ACA's tax credits, although the premium support idea came first. So ACA is pretty much like premium support. Moving on to the next slide, let's look at how premium supports would be set. how would those dollar amounts that people would get be determined? Its value and adequacy, the value and adequacy of the payment that people receive, would depend on the rules that are used to set it. And premium supports could be set in a variety of ways. And we've had proposals that would base the amount people would receive on costs per person in a prior year with an index for inflation, so a fixed amount. An alternative is to do it like based on insurer bids in any given year. And if you think of the approach, it could be the average of those bids. If you think of the approach used by the ACA, the amount could be set at the value of the plan that was the second lowest cost plan. That is what the ACA does. And then going on to the next slide, you can see how these premium supports, and they are alternatively called vouchers. Next slide. That's how they would be used or how the system would work. Plans would determine their own premiums. Consumers would choose the plan to which they wanted their premium support, that government contribution, to apply. And beneficiaries who choose a plan that costs less than the contribution amount would pay less, would save some money. And they would have to pay more, add on to that voucher, if the premium exceeded the government contribution. That's basically how premium support would work, and that's, as I said, got a lot of similarities to the marketplaces in the Affordable Care Act. The real question that I want to turn to, based on what I said is the argument on behalf of premium support, on the next slide, is whether premium support is a promise or a threat. So to start, I thought it was appropriate to start with the promise, the argument that is made for the value of premium support. The argument is that if people go shopping with a voucher, it will encourage health plans, insurance plans, to compete by becoming more efficient. That's the promise. But the threat is that instead, plans will compete by discriminating against or avoiding the more costly patients or encouraging them to disenroll. It would reward them for reducing the amount they spend on care, so perhaps undermine the quality of care. And because we would be replacing the single government Medicare insurer with multiple insurers, it would actually limit purchasing power and actually raise prices from providers. So what competition will actually do, and we have some reasons for concern in this regard, may be quite different from what the hope is for competition. The second aspect of the promise is that efficiency will slow the growth in healthcare costs. But that too cannot be guaranteed. And there's a very real prospect that the desire to constrain contributions in order to reduce federal spending will constrain the amount of the voucher, and it will grow more slowly than healthcare costs. Or said the other way, the costs are going to grow faster than government contributions. Now going to the third aspect of the promise. If competition promotes efficiency and efficiency slows the growth in healthcare costs, lower costs are going to facilitate our ability to finance Medicare into the future. That's the argument that is made, that we need premium support, it's claimed, in order to save Medicare for the future. But the threat is that the government savings will come not from efficiency, that the competition will not be even around efficiency, that government savings will come at beneficiaries' expense, with beneficiaries rather than the government program bearing the risks of rising healthcare costs. That's the threat of premium support. And as I said, given experience with healthcare plans in and out of Medicare, there is legitimate reason for being skeptical of the claims that are being made. That said, and we'll go on to the next slide, I want us to consider 4 strategies that actually would secure Medicare for the future, that actually can live up to the promise that Medicare already offers. The strategy has 4 parts, and the reason that I'm focusing here is going back to what evidence I presented at the beginning of my remarks. There is a real problem in terms of rising Medicare costs as a share of the economy, a share of the budget. And there is a real concern in terms of making sure that that Medicare is collecting adequate revenues to pay its costs. So I'm going to look at 4 pieces of 4 strategies that can address those problems that do not raise the threats that are raised by premium support. The first is cost containment, keeping Medicare spending per capita growth low. And the strategies that we have begun to pursue for moving away from rewarding providers for providing ever more and ever more expensive care, and instead to focus on providing care efficiently and effectively as regulated and monitored by government for quality of care, that we should continue to pursue those changes that are generally known as payment and delivery reform. The slides I showed you earlier on CBOs having to change the Medicare spending projections gives us some real hope that we can do a better job on containing costs in the future, much better than we've done in the past. Most of those reforms focus on avoiding unnecessary services. What we also need to do then is a second point if we want to contain costs, and that is pay more attention to whether our prices are too high, to overpayment as well as overuse. That is more challenging to providers and harder to do, but something that is necessary in order to get value for the dollar. Now, turning to the next slide, look at a second strategy. And that is not about containing costs. That is about securing Medicare by making certain that its benefit is meeting the needs of its beneficiaries. It's important to recognize that Medicare is stingy, not generous, relative to employer-sponsored insurance, and more importantly, relative to the needs of the beneficiaries. I've listed some of the benefit gaps on this slide. There is no cap on out-of-pocket spending, which is now standard in employer-sponsored insurance and now in the ACA marketplace plans. There are inadequate cost-sharing protections for low-income beneficiaries, much less adequate than ACA provides. And there are plain old holes in the coverage for dental care, hearing aids, and a huge gap in terms of long-term services and supports. So if we really want Medicare to live up to its promise, we need to make sure that the benefits are actually there for beneficiaries and meeting their needs. The third strategy on the next slide is better management of Medicare. Traditional Medicare lacks mechanisms to exclude any providers from participation in the program. No way to avoid even providers who have been demonstrably over-providing poor quality care or perhaps engaging in fraud. And in addition, overpayments in Medicare, overpayments in another part, in the part of Medicare that makes payments to private plans called Medicare Advantage plans, overpayments to those plans allow them to attract healthier beneficiaries with extra benefits, pulling people out of Medicare's overall risk pool and putting beneficiaries at risk when they need care. So some years ago, the Medicare Advantage plans were included in Medicare. This was in 2003. And now about a third of Medicare beneficiaries are in these private plans. And the policy has been to entice people into private plans, which raises, although it's not premium support, people continue to get access, traditional Medicare. It is enticing people into private plans and is kind of a camel's nose. We just have to keep the rest of the body out of the tent by addressing those overpayments. Next slide. The final piece of the strategy for securing Medicare, and we should not be afraid to recognize it, is that we need more revenues. I showed you that Medicare cost growth is made up of both costs per growth and costs per capita per enrollee, and in the number of enrollees. And the number of enrollees has become a dramatically large portion of the growth as the elderly population grows in number and grows as a share of the population. The reality is that cost containment alone is insufficient to finance that growth. And we need to recognize that more revenues, whether they be in payroll taxes or in general revenues, are needed to support Medicare protections. Moving right along to the next slide. So when we ask the big question, can we make Medicare safe? We can if we're wary of reformers who promise to save Medicare, but are in fact undermining it. And if we challenge those who ask whether we can afford Medicare, I should have noted earlier and will note now that estimates are that, and we need to remember this, that as the economy grows, that that everyone will be better off, and that a couple of points of increase in tax levels for the working age population will only slightly reduce their economic improvement over time. It will not be a major sacrifice. So this is not about affordability. It's really about focusing on mustering the political will to support adequate, affordable care. So to close, my last slide raises my final question. I would argue that the bottom line for whether or not we can keep Medicare safe is a philosophical and a values question. Are we all in it together, supporting an adequate insurance plan that really does protect Medicare beneficiaries against the financial risk of needing a great deal of care? Or are we moving to a society in which it's pretty much every man, woman, and child for him or herself? It's clear that I'm for the all in it together mode, and I hope I have persuaded you that you should be too.
Well, thank you so much, Judy. At this point, we'll turn to your questions. Remember that you can type in your questions at this point or any point in our conversation. You just open the question box that you see on the right side of your control panel and type your questions in, and I'll ask them. So let's start moving to those if we could. A few weeks ago, we had actually dueling press conferences in Congress, one calling for Medicare for all and the other talking about state vouchers as the solution to healthcare issues. So could you talk specifically about what Medicare for all means and how you see that being a part of this discussion?
So what I focused my remarks on is Medicare for Some, which is the current Medicare program for older Americans and some people with disabilities. Medicare and it is overwhelmingly a government insurer, so a single payer. I gave you that there's another part of Medicare that is not, but let's focus on traditional Medicare. So there's one payer, not multiple insurers. Government is the insurer. And Medicare for All is the term that is generally used for developing a similar program for the entire population. And what that means in general, or in its simplest terms, and I think that is the way to understand it, is that it would be a tax-financed program that would provide, under which everybody would be covered, and people would not be looking for private insurance except to the extent that there was some need to supplement coverage. Now, that's what it means generally. What it means specifically, it remains to be determined. And so Bernie Sanders has put out a legislative proposal, and with lots of decisions about the generosity of benefits and some details on how the program would work, but not details on how it would be paid for. It should not be, his model is much more generous in regard to benefits than is traditional Medicare. There's not been talk about, nobody's reached the level of detail about whether everybody's in the same program, and that's where seniors and people with disabilities would migrate as well. It might make sense. But that it's essentially saying we've got a government program for Medicare for older people and some people with disabilities. We ought to have that for everybody. What that program ought to look like is not very well specified. So I think what it bespeaks is that Medicare works and would work better than a private insurance model, and that we ought to stop trying to patch up our patchwork healthcare system. But it also would mean that all the private health insurance that people now count on would go away, and that all the spending, the financing for healthcare that comes through employer-sponsored insurance and our premiums would now be coming through taxes, which means they're quite an explicit increase in taxes. Doesn't mean it wouldn't be less expensive as a plan, but its financing would all be on the federal budget.
Are you still with us, Judy?
Looks like her audio is still active. She may have cut out on her cell phone.
Okay. All right. One of the things that I think people want to talk about with the specific issue around Medicare for All is how it fits together with other federal and other programs like Medicaid, for example. So one of the questions when Judy returns is that we'll come back to the issue about how this is related to the Medicaid issue. So she's calling back in, and we'll see her in just a moment, hopefully. Hold on just a second.
Okay, she's back.
Judy, are you there?
Yes, and I was so eloquent. Where did you lose me?
I think we got all of your answer, and then after that you disappeared. So
okay, because I said John, was that sufficient? And all of a sudden there was nobody there.
Well, it was certainly sufficient. But let's turn now to the next issue, which is obviously there are lots of suggestions and proposals around Medicare, but there's also proposals around Medicaid, which of course for older people is also an important resource, particularly for long-term care services and supports. So how do you see these proposals coming together, or do you? I mean, there seems to be an enormous cut in the Medicaid budget assumed in the House proposal on taxes. So how do these things fit together?
Yeah, well, they fit together in that they reflect a similar philosophy, which is rather than, or better said, it is transforming the current financing mechanisms, which guarantee federal benefits that are sufficient to pay for the promised services and any growth in the population. That's true for both Medicare and Medicaid. To transform the programs from that kind of financing to capped federal funds. So in the Medicare premium support, it's a capped amount to shop for health insurance. In the Medicaid proposals that we see again in the budget, but we also saw in the ACA repeal and replace legislation, it's capped federal financing either as block grants to states that would cover growth in any growth in the population as well as growth in the per person cost, or we've had more attention to providing states fixed per capita amounts. So allowing spending to grow with enrollment, but not to but constrained in the amount to which that amount will grow with rising healthcare costs. So what that for that is that fixing. Anytime you fix the amount independent of the cost of service or not directly tied to the cost of service, you raise the question as to whether the amount is going to be sufficient to cover the costs. And so I raised that with respect to the premium support, and you'd raise the same thing about a capped federal financing arrangement. For the elderly, the concern is most important on the long-term care side because, as we know, Medicaid, not Medicare, Medicaid is the nation's safety net for people who need long-term care. And as the elderly population both grows and ages, more old, we baby boomers are going to start turning 85 in 2031. As we get older, we are likely to need more long-term care. And if the total amount of funding is fixed with a block grant, there is every reason to be concerned that the money will be insufficient to support the growing care needs. And even per capita amounts, even ones that purport to be relatively generous, are insufficient to address the enormous holes we have in adequate long-term care funding, especially care at home, across the nation. So we underfund long-term care in contrast to health care. We underfund it. And it does not account for the growing needs with the aging of the population. So it is of tremendous concern. As I said, and I'm not certain about as I think I indicated at the outset, the budget has language on both Medicare and Medicaid, and the question is whether that language and that the sizable cuts you referred to are binding. If in fact it is determined that those are binding, then the Republicans are pursuing through the budget resolution the same activity they were pursuing in the ACA repeal and replace activities. So there is, as I said, we need to be vigilant all the time.
So let's talk a little bit about the local impact on these changes. One of the issues, as you know, that we've been involved in is looking at rural aging. And do any of these changes impact, for example, the stability of rural hospitals or federal clinics that are in underserved areas?
Well, again, I would say that any time that you constrain payment that you are potentially putting access to care at risk for people who live with limited access to providers. Those providers, the hospitals are unlikely to walk away, but if payments are constrained, then there's reason for concern. Some of that is there are changes in healthcare that may make it more efficient for people or it might providing access to transportation that will get people from rural areas to urban communities certainly for specialty care and tertiary care may be desirable, and that rural hospitals can hopefully rely more on telemedicine and connections with more sophisticated providers to compensate for some of their limitations in having access to specialists and being able to provide those services. But the underserved areas are underserved areas, and you're right to be looking at that area, at that aspect of service provision and providing connections, but because it is a problem. And when it comes to long-term care and family, the availability of whether it's paid services or family care, that's a huge problem in rural areas because of the distances people have to travel. So we just need to keep shining a light on it, so that we remember that that rural communities may need some extra attention as delivery systems change.
As you know, as part of the Affordable Care Act, there was a requirement that there be better integration of hospital or acute care and long-term care systems in a variety of ways, and we've seen a variety of programs spring up around that. Do you see that model as ending if these things move forward, or do you think that the potential integration of those two systems will continue one way or the other?
Well, I'm not sure exactly which measures the questioner is asking about. I'm going to talk about. I'm going to turn to dual eligible demonstrations, and so if the questioner wants to add some more material, please let me know. But the biggest focus, I would say, in the Obama administration, and along with the Affordable Care Act, was on combining Medicare and Medicaid funding in capitated plans for low-income Medicare beneficiaries who are eligible for both Medicare and Medicaid. And the concept, again, was to, as the questioner said, was to promote attention to the full range of services that people need, same people who need acute care, need long-term care, and to deliver that care efficiently, effectively, so that you don't, if you can keep them cared for effectively at home, they are less likely to end up in nursing homes or in emergency rooms or in hospitals. So an incentive to use the dollars of the two programs together to provide better care for people more efficiently. The problem that I see with any of that depends on paying plans certain sums and counting on them to do the job well is the risk that we're farming out the job of making sure that people are receiving adequate Medicare and Medicaid services. And no matter how low people's incomes are, if they are Medicare eligible, they are Medicare beneficiaries. So I do think that there ought to be attention, definitely, to making the system work across the range spectrum of services for everybody. But I'm not sure that the way to do that is to turn over Medicare dollars to essentially to Medicaid plans. So I do think that there is some attention within Medicare to these kinds of issues, but not as much as there should be.
Thanks. Going back to your comment about potential bad actors in the system and the difficulty of controlling that in the Medicare system, the questions around the intense interest right now in the opioid crisis that has been sweeping the country, but now really has caught everyone's attention. Perhaps a presidential proclamation today around it. What would changes in Medicare specifically, but in Medicaid as well, have on our ability to actually do some of the effective things that we need to do to control this epidemic?
Well, it's the opioid crisis is a very good example of why we should not cap Medicaid. The opioid crisis it demonstrates the need for a system that can respond to epidemics, whether they be stimulated by the overuse of pharmaceuticals or come from bugs or viruses. It's the beauty of the Medicaid system is that when something major happens, that the Medicaid system and the open-ended matching of state spending, but with federal dollars, to rise to the need that the Medicaid program can take it on. And so Medicaid has been very valuable in terms of supporting treatment for people who have become addicted to opioids. And I've seen some call out the irony of simultaneously calling for caps on Medicaid and then calling for attention to the opioid epidemic. They're inconsistent. On the Medicare side, I would argue that that there needs to be, and I think everyone recognizes this, greater attention to the way in which opioids are prescribed, and that means greater accountability. And this part of Medicare is all in private plans, but we need the federal government to exercise responsibility with respect to those plans, and the plans exercise responsibility with respect to providers. And I guess it's also Medicare through physicians. I shouldn't miss that. It should be through physicians. Attention to physician behavior. Medicare has a responsibility for promoting appropriate prescribing. And Medicare is, the history of Medicare has been, it's written into the statute, promises not to interfere in the practice of medicine that is grossly outdated, may never have been appropriate. It is Medicare's job to pay attention, and that's what it means to run a federal program.
I think we have time for just one more question, and I will ask you to give your final words to our audience. So if you were a federal leader, how would you see the most, I don't want to make this a fantasy question, but but what of the different models that you presented as potential alternatives, which one do you think is probably most likely, and which one do you think would be most beneficial?
So I didn't mean actually to present them as alternatives. We need to do all those things. And so we need to, walk and chew gum and recognize that as a federal program that we need to invest in federal administration and both in personnel and resources and politically in an effective Medicare program then that can effectively, I'm using effective a lot, deliver the services that people we ought to have. And that means, and so it's not a bad place to end, we need to strengthen the traditional Medicare system and not farm the responsibility out to private plans. That's a cop-out, and will be a cop-out because we farm things out when we are politically weak and not willing to invest in government, and then we end up unable to monitor the private plans that we have decided to rely on. It's a very big risk, and we should not go that route. So what I would argue is that we should continue to invest in cost containment. I'll reemphasize that path, which has been generated by the ACA. There has been some pushback on it, but it is still alive and well and needs to be encouraged. As I said, we need attention to cutting some payments to providers, which we are loath to do. So people who care about the program need to educate constituents that some changes or some reductions in payments are not cuts to them, but are needed. We're wasting money, that we shouldn't be wasting money. We need to educate people that Medicare is not too generous and that Medicare beneficiaries are not greedy geezers. We need to have meaningful benefits in Medicare, and that requires some benefit improvement. As we said a moment ago, Medicare needs to step up and gain the authority and use the authority to manage the program well and not cede ground to private insurers. And finally, we need to suck it up and raise more revenues. And I am a member of the baby boom generation, and I am still earning, and we should not be cutting my taxes. We should be raising my taxes in order to strengthen the Medicare program. So that's my message, is that this program works. It works. It is more efficient than private insurance. It is a guarantee to everybody that we are all in this together, and we need to do everything we can to keep that commitment real.
Well, thank you so much. I want to thank Dr. Judith Fader, who is professor at Georgetown University, for her participation in today's program, and also to thank her for her everything that she does to make life better for older adults. I also want to thank West Health for their support of this webinar series, which makes it free of charge to our participants. We will be making a recording of this interview available with both the slides and audio. Please watch for an email to be sent later with the rebroadcast link. And finally, I want to thank all of you for participating in today's webinar. Have a great day.